As you can see that Rajni has beautifully planned it, that we went ahead with technical aspects, then we moved on to the normal EEGs and then abnormal. And in abnormal, we first covered the benign ones, and now we'll be moving towards the more sinister epilepsy syndromes that we encounter day in and day out. So this is the topic that I have been given. Before I get into the topic itself, I would just make sure that everyone is on board, and we'll start with the most simple thing, or the first thing, that is, when do we call someone to have epilepsy? So the age-old definition has been there that if you have 2 or more seizures 24-hour apart beyond the neonatal age, we call them as epilepsy. Now, but beyond that, we in our clinical practice, we used to have patients where we would establish the diagnosis at the first go itself, start therapy. And this we have been doing right from the very beginning. But this was never on pen and paper, It came in 2014 only, after the ILI actually modified this definition of epilepsy. So what it is saying now is that though you can obviously diagnose epilepsy with 2 seizures, but you can also diagnose epilepsy in certain other scenarios. And what those scenarios are is that even if you have a single seizure, but you think that the possibility of further seizures is as high as it would be when you have 2 or more seizures. I'll give you an example to explain myself. So say if you have a child who has got Ashleigh macules, who have got adenovus sebaceum, what is the diagnosis of the child? Tuberous sclerosis, and he came to you with first episode of seizure. So why do I want to wait for him when labeling him as an epileptic child and start him on therapy? There's no point, and that will not be actually ethically correct as well. So those things were not there in the previous definition, but now it is. So now this statement stays false, that you can only diagnose epilepsy when you have 2 seizures. So you can diagnose if you have a single seizure, but in a specific setting. The other thing is that if you are intelligent enough to get to a epilepsy syndrome diagnosis, the very first go itself. So it should not stop you from initiating a therapy or your management as per that epilepsy syndrome. If it is a benign one, then as Dr. Saurav has said, maybe sometimes they might not require any therapy. But then if you are able to establish an epilepsy syndrome right after the first go, then also you can establish the diagnosis of epilepsy. So with this, I'll proceed further. And what we do naturally, or what we do in our clinical practice, is to have some sort of a simplified approach. So if we see a child with seizure, the first thing is that we see that whether it is a seizure or it is some seizure mimic or a non-epileptic event. Once we are sure, then we try to qualify it into whether it is a focal seizure, a generalized seizure, or sometimes we don't know whether the onset was focal or generalized. Once we have done that, then we get to the next, please. So then we get to the diagnosis of epilepsy. So this would depend upon whether you had just focal seizures, both the seizures only generalized, or where the onset was not very clear, as it is the case in infantile spasms. So we don't know whether it is a focal or a generalized seizure. So then you get to the diagnosis of epilepsy. The third thing is then you would want to understand why the child developed this seizure or epilepsy. So you will go to the etiology. So etiology in epilepsy can be divided in these 6 types. So one of them would be a reason for the child to have a seizure. Maybe you will come to know about it at a later evaluations, at a later stage, once the full-blown picture is evident or your full workup has been done. But this is how you proceed. And once you have done this, then you would like to tease out certain things. Is it any specific age group, a specific form of seizure, a specific type of prognosis can be given to them? So you would start thinking that can I give a label of an epilepsy syndrome? So this Dr. Saurav has already told you. So this is how we go ahead in our approach towards an epilepsy syndrome. But there's one thing more to it. So our management of seizure or epilepsy is never complete unless and until we look at the comorbidities. So that would complete your evaluation. So you need to identify your target points which you want to treat. If you don't identify the behavioral issues and the other problems, the sleep-related issues that the child has, then maybe just treating or decreasing the seizure count is not going to help you, specifically when you are dealing with sinister form of epilepsy syndromes. So these epilepsy syndromes can be multitude. We have seen, you have already seen how many Dr. Saurabh has already elaborated. Some of them will be taken by Dr. Vishrup, and a chunk would be taken by myself. So these, when we say that there is an epilepsy syndrome, when we see that there is a conglomeration of certain signs and symptoms, we have a specific age group in which they are appearing. There is a specific seizure type which is there. There is a specific mode of inheritance which is there. There is a specific way in which it is progressing, and then there are certain specific treatment options that are. So mind you, their etiology can be heterogeneous. The same syndrome can be because of a structural substrate. It can be a genetic etiology. It can be a metabolic etiology. But the key here is the epilepsy syndrome, which will help you, as sort of already said, that then it is easier to give you a unified approach. Then the approach across various pediatricians or pediatric neurologists is going to be similar if you are able to say that there is a particular syndrome that is it. Now, till here, it was all what we have discussed till now. But my topic would be dealing with those epilepsy syndromes who are sinister enough, where the epileptic activity itself creates a vicious cycle of on and on neurocognitive decline. Now, this is beyond what you will expect from the underlying etiology. So what do I mean by that? I'll give you an example. I have a child with stroke. There is a gliosis present in the parieto-temporal region. So I would expect a seizures coming from that area. But if I see a child who is significantly delayed, or there is a significant cognitive decline, a lot of irritability, aggression, behavioral issues with seizures happening. So all these things will not be explained by this single focal seizure or a single focal lesion. It appears that because of that, it has triggered a vicious cycle where it is also suppressing the whole neural network of other areas and leading to this significant or a very dramatic presentation. So this is this syndrome, or these type of epilepsy syndromes, we call them as epileptic encephalopathies, and the recent name is developmental and epileptic encephalopathy. So this can be easily divided among the various ages. So we have certain specific ones that are there in infants, then in toddlers, and then in childhood. So it makes it easy. So you can see that these are very age-dependent phenomena. In fact, most of these epilepsy syndrome have this very characteristic point that they are age-specific. They'll come in at a specific age and they will burn out or evolve into another epilepsy syndrome at a certain age. So this is actually a whole continuum. So let us start with the first one. Now, this is a 2-month-old child who came to us with seizures, which were, I'll show them to you. So these are the seizures that used to happen that were there from the second week of life itself. And there was no attainment of any milestones. There were the head circumference you can see is normal. There was no neurocutaneous markers. There is no dysmorphic features that are happening. And what we can see in the event is that there are some tonic posturing that is happening. There's arcing of the back. There's some automatism of the upper limb happening here. And in between, you will see that there is some arrest of activity is also happening. So this is a classical tonic seizure. And in neonates or in early infancy, the corpus callosum is not appropriately developed. And that is one thing which is responsible for a generalized presentation. So that is why the notion is not right that generalized seizure will happen in neonates. It is possibly that focal seizures are more there in neonates. So we see that, okay, this is the scenario that we have, and the development is not age appropriate, then we need to think of, I'm dealing with some sort of an epilepsy syndrome or an epilepsy for that matter. And the first investigation should always be to quantify the electrographic correlates that this will have. So the electrographic correlate will be the EEG that we will see. So we got an EEG done, and the EEG showed that there were some bursts of activity that were happening. You can see these bursts of activity which are there, and there is a period of quiescence or suppressed activity which is there. So we call it a burst suppression pattern. So whenever you have these bursts and suppressions happening, here you can see that the suppression is actually from 3 to 5 seconds, and the bursts were there at least 2 seconds, sometimes 6 seconds. So this is a classical picture of a burst suppression in a young infant who had seizures in the form of tonic seizure. So what epilepsy syndrome label we are going to give? Any of you feel free to answer, Okay, never mind. Yes. Okay. I'll get into the detail why there is a mismatch between the two answers, but both of them are right. But now what we see is that there is a electroclinical syndrome. I see a specific electrographic picture, and there is a very specific pattern of evolution, which was tonic seizure predominant in the initial 2 weeks of life, and there was complete stagnation of development. The EG signature was also evident in form of burst separation. So this qualifies for an electroclinical diagnosis of Ohtahara syndrome. So these Ohtahara syndrome, previous literature has said that it is mostly there with brain malformations or in certain genetic setups. Metabolic causes are less likely to cause Ohtahara syndrome. And these actually evolve with as age passes. So when the child is 5-6 months old age, then it will evolve into West syndrome, and by 2 to 3 years, it might evolve into the Lennox-Gastaut syndrome. So the key here is that if we are able to identify them, start our treatment early, we might be able to stop this dreadful progression. A similar sort of an epilepsy is an early myoclonic encephalopathy. Has an age of onset on similar in a similar manner. In the initial first month, the seizures would start. The seizures here would be a bit phlegmatic, more of myoclonus, both focal seizures and tonic seizures, which can actually also happen. The development is delayed, and people say that these are mostly because of metabolic etiologies. Otherwise, also as a concept, metabolic etiologies lead to generalized affection, and they are present as myoclonic germs. Structural substrates, they can present as a focal tonic-clonic seizures. But this will not hold because the brain is still immature. So there was a distinction that is reported in mostly in the previous literature about the burst suppression pattern that we see. So they try to differentiate between the two. They say that it is mostly seen at the onset of the seizure in Ohtahara, the burst suppression pattern, while it appears slightly late in EME. Similarly, the suppression is quite prolonged in EME, while it is short in Ohtahara. And in Ohtahara, you would see it across all levels of awareness, that is in sleep and awake, while in EME, you might see it in sleep. But with in our experience and the recent literature suggests that this actually is quite blurred, We don't see that there is a clear distinction between the two. And now we have molecular and cytogenetics available to us. We easily get genome sequencing done. So we see that the same genetic etiology is presenting with both the presentations. And the management is also not differing. It depends upon what type of EEG is and what is the actual etiology. So therefore, you might choose to, instead of calling them specifically as these electroclinical syndromes, you start calling them by the underlying etiology. So there you might have a broad syndromic diagnosis that I'm dealing with some sort of an early infantile onset epileptic encephalopathy. And the electroclinical diagnosis may be Ohtahara, but the etiology is going to define. If it is a hemimegalencephaly, then I would straight away go ahead with some surgical options. If there is a metabolic possibilities, I would try to correct that. And if there is a genetic, then I'll counsel them, and based on those, I'll start some precision medicine if there is some drug that can be preferred in that setting. So this is how we approach these cases. But mind you, as Dr. Saurabh has already said, that at the first go, you will not be so clear that it is a benign myoclonus. Is it a sinister early myoclonic encephalopathy? So in the initial few days, you need to be very observant. So we'll always think that you should not be missing a sinister diagnosis, but at the same time, you should not be overzealous in initiating therapy. So observation for some period so that you can exclude. Sometimes benign etiology in the initial months is a diagnosis of exclusions. When we are sure that we have observed for 3 months and this is how the child has evolved, so maybe there is no sinister etiology and we can safely keep a diagnosis of a benign entity. So moving on to the third case. Now this is actually the first case itself. So that was at 2 months age, and this video is of a 5 month age. This is the same kid. Sorry, the kid on the left. Okay. So if you see the kid on the left, now the seizure has changed. So what is the semiology here? We see that there are certain forward jerks which are happening in clusters. And if you take history, then you see that these are more when the child wakes up from sleep. And we know by the history itself that the child is significantly dealing. So in this setting, we are very clear that now we are dealing with a child with West syndrome. Very sometimes even West syndrome might not have this preceding history of developmental delay and previous seizure types, and it can start de novo also. So there, this thing becomes very important that you actually closely observe. Now this is another video of another child. Sorry. Can you run the video on the right? Now this is again a 5-month-old kid who is developmentally normal. The child was sent to us with a diagnosis of infantile spasms. So we saw that there are episodes of subtle stiffening that are happening, but on history we found that these are more when the child has been fed, and the development stayed perfectly normal. The outside EG was also normal. So we safely diagnosed that this is not an epileptic diagnosis. This is a plain shuddering attack. So there is a wide variability in the presentation. And this is what I actually, my key message today would be for you guys to identify. You should be able to identify this, which one is a spasm, which is some benign form. And if you have a doubt, don't be very eager to give a diagnosis at the first. Get an EEG, because this West is a electroclinical diagnosis. The electro part has to be added to the clinical. So the child on the right was actually just shuddering attack, but sometimes you can have normal development at onset, specifically in those who don't have a structural substrate, where it is de novo cryptogenic. There you might have, and later on, but definitely the development is going to stagnate. So the EEG, so all EEGs till now, what you have seen, Dr. Goswami, Dr. Rajni, Dr. Saurabh has shown you, all they were beautiful looking EEGs, if you compare it with this. So this is one EEG where you can, a single one word would be a completely disorganized and chaotic EEG. So everyone agrees to that or not? So there we saw some waveforms appropriately going around, but here we don't, we just see large amplitudes, slow waves, and there are multifocal spikes happening from here and there. So this is the true picture of hips arrhythmia. So compared to them, it appears very easy that yes, diagnosing hips arrhythmia on EEG is quite easy. I'll get to this later. Now the classical description of hips arrhythmia was given by Gibbs and Gibbs, who defined it as random large amplitude slow waves with focal, multifocal spikes and polyspikes happening at variable places, and which can change as well. But which time we realized, because this is an EEG based epilepsy workshop. So again, like Dr. Saurabh, I'll be also focusing more on the EEG and clinical diagnosis rather than the management. So, but the key thing through this slide, I just wanted to let you know that still the issue here is an early diagnosis. Because see, these are sinister epilepsies, and the only thing which is modifiable and which is there with you, which can change the long-term outcome, is an early diagnosis and initiation of prompt definitive therapy. So that is lagging, not in India, but elsewhere in the world as well, but we are lagging more. Now, so what we have in treatment, we all know that the hormonal therapy is there as the first line drug, and then vigabatrin we have in those who have tuberous sclerosis. But if someone has failed hormonal therapy at the first one, vigabatrin is the next best choice. And then if they have failed, then we have line of other drugs, and sometimes we also resort to ketogenic diet. So let us come back to the hips arrhythmia. So now hips arrhythmia that I showed you, that chaotic picture, is also not very uniform. That epilepsy has got a spectrum, the EEG also has got a spectrum. So now people over time have realized that there are certain variants of hips arrhythmia that also exist. And the true picture is that the variants are more common than the classical hypsarrhythmia itself. But then, does it correlate with the prognosis? Is any specific etiology suggested by a particular pattern of hypsarrhythmia? So that correlation, it doesn't exist. So I just show you certain epochs so that you can have that visual pattern recognition. So this is again a hypsarrhythmia, but here what we are saying that there are some episodes of attenuation happening along with the burst, as it was there in the burst suppression pattern. But here the suppression period is not very prolonged. It would last just for a second or two. So here bursts of large amplitude activity with periods of attenuation better visualized in this EEG. So you can have this in a clinical background of epileptic jerks happening. The other variant is an hemihypsarrhythmia or voltage asymmetry. So you see that the right side, which is the even ones, they are appearing very chaotic, but there is complete asynchrony. The left, that is the green electrodes, they are appearing quite organized compared to the right side. So this is a hemihypsarrhythmia. Then this is another variant where instead of asynchronous, there is a hypersynchrony there. So there's increased synchronization between the two sides, but still the background, that is the large amplitude slow waves that are there. So we have two more variants. That is, there can be a single epileptic focus, but with a large background activity, large amplitude background activity going on, or they can be some variant. Sometimes you see a slow wave variant where epileptic activities is not very commonly seen. So these are the 5 variants of hypsarrhythmia. We call them modified hypsarrhythmia. But the key thing again here is that it does not tell you that the disease is mild. It does not correlate with your formal or final prognosis. So it is just that you don't get confused and you misreport a modified hypsarrhythmia as non-hypsarrhythmia. That should not happen. Now there are more problems to hypsarrhythmia. Now I showed you that it was a very simple visual pattern of chaoticness that helps you label it up. But people, when they actually studied it in a formal manner, then they saw that actually it is quite subjective. I might consider something as large amplitude, the other person might not. So they saw that the inter-rater variability or reliability, is not there. And people have even reported that this can be actually a threat to all the clinical trials validating so many drugs here. So therefore, the researchers thought of developing some scores. And then a recent 2015 publication, they came out in epilepsy research about a BASID score. Now, this is burden of amplitudes in epileptiform discharges. What the authors suggested that you look at the 5-minute most sinister appearing epoch. You choose that. You choose the bilateral, double banana, longitudinal montage that has already been told to you by Dr. Goswami. And then you see 2 important factors. You see large amplitude slowing. They have defined it as more than 200 microvolt, and multifocal spikes, which they have defined as more than 3. It can be there in one hemisphere or it can be there in both the hemispheres. So based on that, they have graded this. So the grade 4 and 5 of BASID score, it's actually similar to hypsarrhythmia. Grades lesser than that are not considered. But there was an issue with this also. So this came in 2015, but then those who read EEGs, they'll know that even in normal kids, there is an occipital slow waves which have larger amplitude, especially at this age. And I have shown you multiple patterns, modified hypsarrhythmia, where there is attenuations happening. That attenuations will not have large amplitudes. So because of all these things, they thought this may also need a revision. So in 2021 itself, in July, few months back, they came out with a revised BASID score. Now this again now talks about some additional factors, that is paroxysmal voltage attenuations happening, and they are calling grouped multifocal spikes. Multifocal spikes, if there are more than 50% of the 1 second pins, then they are given a particular score. If they are less than 50% of particular of the whole EEG or 5-minute EEG record, then the score differs. So we will discuss it when we are actually dealing with the EEG. So let us move on to the next epilepsy syndrome. Now, this is a 2-month-old boy who has taken issue of a non-consanguineous parents. He started to have multiple focal seizures from day 3 of life itself. Now, these were refractory to multiple anti-seizure drugs, and paradoxin trial was also given, but the child didn't show any response. The initial neurological examination was normal. There was no neurocutaneous markers. There was no dysmorphism present, but gradually there was significant encephalopathy that set in. The MRI brain was done in the initial phase, which was also not revealing any abnormality. So what we thought, okay, we'll first go ahead with the most important investigation, which is an EEG. So we got an EEG done, and the EEG showed that we captured ictal events in that EEG. So EEG showed that while one ictal event appeared from the right electrodes, you can see that the right C4O2, T4O2, they are firing continuously. So this was an ictal event which was happening, and the ictal focus was on the right side. In the same EEG record, next time we found that the ictal focus was coming from the left hemisphere. So what we saw that there is migrating focus which was moving from one hemisphere to the opposite hemisphere. So this is this setting of a progressive neuroregression, very early onset seizures, which are multiple in numbers, helped us to establish the diagnosis of malignant migratory partial seizures of infancy. Now, partial is what the word which is not used. Benign and malignant are also now obsolete. So now the word is epilepsy of infancy with focal seizures. So this child we published it in Brain and Development and European Journal of Pediatric Neurology. And this child or this entity actually mostly has a genetic basis. The common 50% of them would be because of KCNT1, and some other genes are also implicated here. But the worst part is about this, that it is a very sinister form of epilepsy, very sinister. And a few cases that are reported worldwide is that they respond to quinidine, which is an anti-arrhythmic drug, which is not easily available also. So if you timely, you are able to start a quinidine here, or you put him on ketogenic diet, then you might wait for, or you might hope that the child responds to it. But if that is already delayed and the whole vicious cycle has already set in, then you would lose. And we also lost the child, though we did start him on ketogenic diet and we did start him on quinidine with ECG monitoring, but we failed to save the child. So the characteristic thing here is that if you are able to record these ictal events, you will be able to demonstrate the migratory pattern of these ictal focuses from one lobe to the other or one hemisphere to the other. So that is the only way by which you can actually establish the diagnosis. So let us move on to the next case. Now we'll moving towards the toddler age group. So here this is a 2-year, 5-month-old girl who came to us with global delay, and there were frequent seizures that were happening from 4 months of age. The baseline development till 4 years was more or less appropriate. There was some mild delay was there in the cognitive domain. Birth and perinatal period didn't suggest anything. Not getting into the detail of the seizures. So the first seizure happened within 12 hours of the DPT vaccine, which was given at around 3.5 or 4 months. And then the semiology at that time was a left hemiclonic seizure that lasted for 7 to 8 minutes. The next seizure again happened, which was also a fever triggered, and it happened on the right side and lasted for almost 8 to 15 minutes. Thereafter, there was frequent seizures happening, 1 or 2, which were hemiclonic in nature, sometimes right, sometimes left. 60% of overall seizures by 1 year of age was actually seizure fever triggered. Then there were occasional GTCS, which also started. And later on, by 1 year of age, we saw that the cognition is significantly getting delayed. So there is a worsening or decline that is happening. The neurological examination was otherwise normal. The EEG that we did in the initial phase was normal, but subsequent EEG showed that there is some slowing happening and some polyspikes happening. But there was no EEG signature akin to the previous epilepsy syndrome that I have showed you. So what is the diagnosis here? So now we know that there is stagnation happening, so it cannot be a benign variant. There are seizures which are fever triggered, they are hemiclonic, there is changing laterality. Had it been a structural substrate, the structural substrate is not going to change. So in that case, so that is also ruled out. So what we are left with some sort of a genetic predisposition to this epilepsy syndrome. So this is a very classical example of Dravet syndrome. That is severe myoclonic epilepsy of infancy, and it is secondary to sodium channel gene defect, which is SCN1A. So the characteristic feature is a very frequent febrile and afebrile seizures that start primarily with hemiclonic by 1 year. GTCS and myoclonic seizures appear and cognitive delay sets in. The gene is SCN1 in 70 to 80%, but some other genes can also be there, like PCDH19, SCN2A, and other GABA-related genes. The onset, the mean age is between 5 to 8 months, but you can see between 4 to 1 year the onset to happen. The course is then the initial had febrile seizures. Later on, then the catastrophic period begins where other seizure types which are not fever related also happen. And then you are left with the sequel. So now we have identified that Dravet is not a single problem that happens with SCN1. So instead of that, we have started calling it an SCN1A associated epilepsy. And depending upon the severity, we have classified into 4 types. So the sinister ones are called as severe myoclonic epilepsy of infancy, that is Dravet. The benign ones are known as Jeff's plus, where just generalized seizure with febrile generalized genetic epilepsy with febrile seizure plus is there. That is febrile seizures are happening, which might even go beyond 5 years of age. And a borderline scenario where you will not have multiple seizure semiologies, myoclonus, we call them SMEB. And then the most sinister one, which is SCN1A associated encephalopathy, which we see that it starts in the first month of life itself. And it is sinister, and many a time they might not have a fever trigger as well. So you have all these forms where you have to think of a sodium channel. Now, tonic seizures are a bit unusual here, and along with temperature variations, there are other triggers. Sometimes photosensitivity is there. It may aggravate with some physical exercise, emotion, excitement. All these can actually trigger a seizure here. And the EEG is non-specific. It doesn't give us a electrographic signature. But if you do photosensitivity, then 25% of them might show a photoparoxysmal response. So that is one thing that might help you to make a diagnosis. Prognosis is very guarded. And in the Western world, we have some new drugs that are available, FDA approved after 2018, which are stiripentol, fenfluramine, and CBD oil. In India, what we commonly do is that we give a trial of valproate and benzodiazepines, add topiramate. If not responding, then ketogenic diet. So this is the usual way by which we manage kids here. Mind you, need to avoid lamotrigine, phenytoin, and CBZ because these are sodium channel blockers. And in this, the inhibitory internuncial neurons are getting affected, and we don't want to use a sodium channel blocker here. So that is one important reason why you need to establish this diagnosis, or you need to rule out this diagnosis. So coming to the next case, so this is a 4-year-old, 3-month-old child who presented with seizures from 3 years old. The previous development had been normal. There were initial infrequent GTCS 1 or 2 per month, and then by 6 months into the illness, the myoclonic seizures appeared, which were frequent and daily. And then 9 months into the illness, some atonic or dropatic started to appear, which were frequent and 4 to 6 episodes per day. Simultaneously, cognitive decline also started to appear, and the perinatal period was uneventful. The MRI didn't help us in any way. So here, what sort of a diagnosis is coming to our mind? So whenever you have such a setting, you will always think of that I am dealing with an epileptic encephalopathy, or I am dealing with a neurodegenerative disease, I am dealing with some neurometabolic disease. This is how you should start thinking. So had it been a neurodegeneration, there would be significant cognitive decline to begin with, and then seizures would have started. The head circumference would have slowed down, but this is not the case here. It started with epilepsy per se, and then epilepsy led to all the secondary findings. So it appears to be an epileptic encephalopathy. Now, with this setting or this type of seizure semiologies, it appears that we are dealing with myoclonic astatic epilepsy or DOOS syndrome. So here the EEG showed that the awake phase. So how do we say that it is awake? The alpha is not visual to us. By 4 years, we expect some alpha to be there, but we see that there are some eye blink artifacts are there. So there are eye blinks happening, but there is no alpha that is coming. What else we see? We see that there are some myogenic artifacts are also happening. This suggests that this is an awake EEG, but the alpha is not there, or a slow alpha is there. The background is slow. So if in awake stage we are getting a delta or a theta activity, it suggests that something is wrong. The child is not alert as it should be in this level of alertness. In sleep, again the slowing prevailed, but it was interrupted with some burst of spike slow waves. Rajni, can you remove that? Okay. So that shows that again this syndrome does not have a typical EEG signature. The EEG can just suggest that maybe you are dealing with some sort of an epileptic encephalopathy. Now the key things here is that development before the seizure onset is normal. These are more prevalent in boys as compared to girls, and a significant number can have non-convulsive status also. Drop attacks, that is sudden loss of tone, is one key feature which is there, and that multiple seizure types are there, but tonic seizures are not very common. And you need to rule out the other differentials that like LGS or Dravet to establish this diagnosis. It has got a very heterogeneous epileptic underlying genetic etiologies. We have not been able to pinpoint, like in Dravet, we say SCN1A is the causative agent. Here, we are not able to say that. So in that way, it is not very clearly characterized as the previous epilepsy syndromes that I have talked about. So there are multiple genetic abnormalities are there. And sometimes what we have realized that it is because of a GLUT1 deficiency also. So if that is the case, then we know that the treatment will not be anti-seizure drugs. We have to resort to ketogenic diet. So in that way, getting an genetic etiology is going to help us in these cases also. So there are certain poor prognostic markers, which are if you have non-convulsive seizures happening in the initial 2 years itself, or you have early appearance of tonic seizures, or you have significant delay at the very first go, you have myoclonus and convulsive status is happening. So all these things would suggest that you might have a poor outcome. Otherwise, the outcome here is variable. So now let us look at these two EEGs. The EEG on the left side is of when the kid was 11 months old, and the EEG on the right is the same child when he has developed 3 years. So I would just like to show you how things actually evolve. So now you know we have already discussed this. Anyone, any doubt? What is the So the EEG on the left at 11-month-old is showing that there are frequent jerks occurring in clusters. So we know that the child had West syndrome at this age. But by 3 years of age, you see that the seizure physiology is different. If you closely observe, you will see that there are some eye blinking episodes that will happen. And then there would be another seizure form, which will just keep looking at the eyes. Now there would be a event that will happen. Now what do you see here? What I see is that there is a sudden jerk, but there is a sustained tonic component which is there, which is lasting for almost 10 seconds, and the child will take some more time to get back to his own self. So these are tonic spasms that we see in children with Lennox-Gastaut syndrome. So this is how these kids evolve. Now we see that there are some atypical absences which were happening, which were associated with ileal myoclonia, and there were tonic spasms that were happening. So this child has now got evolved into Lennox-Gastaut syndrome, which is again a common but a sinister epilepsy syndrome. But again, as I have said, that it has to have an electrographic component and it has a good EEG signature which has to be identified. So the key thing in EEG of these kids is a 1 to 2.5 hertz spike slow waves. So in this EEG, you can see that there are 1 to 1.5 hertz spike slow waves which are happening, and in between there is some burst of frequent activity or a rapid activity, which is more elaborately seen here. So this is known as generalized paroxysmal fast activity or GPFU. So the two hallmarks of the EEG of LGS is a 1 to 2.5 hertz spike slow wave happening, and which are intermittently broken by these generalized paroxysmal fast activity or GPFA, which lasts for almost 2 seconds. Sometimes you might also see a fragmented fast activity. We call them a fast rhythmic fast activities. These are actually markers of tonic seizure. So if you have all these things, you would know that yes, your diagnosis of LGS is almost proven. You don't have a genetic diagnosis, genetic investigation to prove that, because we don't have a single etiology. Even a structural substrate can lead to LGS, a genetic, a metabolic, sometimes we don't know what the etiology is. So all those things can lead to this syndrome. The key thing is the seizure pattern, where tonic seizure is the most important factor, along with multiple seizure types happening. The EEG is suggesting the common age group is 3 to 5 years, and then you can establish the diagnosis, and accordingly you can prognosticate. Sometimes we also go ahead with epilepsy surgeries here in LGS. So first we try a combination of valproate, lamotrigine, and clobazam. The choice would also depend what is the prominent seizure type happening at that point of time. And if we fail, then we go ahead with ketogenic diet or lesser severe in non-invasive epilepsy surgeries like copper sclerotomy or dissective surgeries are required sometimes. But again, the overall prognosis stays bad. Now, this will be the last. I'll not go any further. Now, this is a 5-year-old child who came to us with frequent seizures that were there for 3 years of age. But over the last 6 months, the seizures have been very infrequent or almost stopped. Last 4 months, there hadn't been any seizure actually. But simultaneously, there has been a progressive decline in cognition and behavior. There has been extreme irritability, hyperactivity, autistic traits are evident, and there's an impairment in the recent memory. The visual word output has significantly decreased. So with this sitting, what should be coming to our mind? Again, so it appears that we need to rule out a epileptic encephalopathy here. So with this clinical data, if I add the electrical data, I might get that epilepsy syndrome, which appears to be LKS. So what is the full form of LKS? Landau-Kleffner syndrome. So I'll get into the detail of that. First, we gotten this awake EEG. So the awake EEG suggests that there's a relatively okay background, but there are some discharges which are commonly coming over the frontal electrodes. They are not very frequent. We move to the other because this was the maximum EEG abnormality that we were seeing in awake. But the moment child slipped into sleep, we see that the frequency has increased and it is also getting secondarily generalized. So whenever you have a significant sleep potentiation with neurobehavioral regression, which is a new onset, you have to keep a possibility of an epileptic syndrome, which is now known as encephalopathy with electrical status epilepticus in sleep, that is ESUs. Now, this ESUs comes in two main clinical forms. If this EEG pattern is associated with diffuse cognitive decline, then we call it as CSWS. If it is coming with only with verbal agnosia, the other domains of cognition are preserved, then we call it as LK. But because the management is not going to differ, and so the best word terminology that now is used is ESU. Okay. This is a unique epilepsy syndrome where the hallmark is not seizures. The hallmark is neurocognitive decline. So in our own study, we found that almost 80% will have seizures and 60% will have active ongoing epilepsy. But the all 100% is going to have significant behavioral neurocognitive issues. Now the onset is between 2 to 12 years of age, and the hallmark I already told you, the initial EEG cutoff was established that okay, if there is a spike wave index of 85%, we will label it as ESCs. But as our knowledge increased, now people have brought this down to 50%. And in fact, new evidence suggests that there shouldn't be any cutoff. If you have a background of cognitive decline, which is not getting explained by other possibly other differentials or etiology, and you have strong sleep potentiation, you should start thinking on the lines of ESCs. And here, by saying this, the management actually drastically differ. I'll get to that. The EG thing, there would be some qualitative things that has to be analyzed. We'll have to look at the background also. As Rajni told you that background gives us a lot of information. So the background has to be assessed, whether it is symmetrical, slow, it is large amplitude, whether the normal waveforms is appearing to us or not, and then the spike wave index. Again, that has different ways of calculating that. So initially people describe that you have to get the whole overnight EEG or one full sleep cycle. But in clinical practice, that is not possible. So what we do is that we get a 40-50 minute record with 30 minutes sleep at least. And we look at the first 15 minutes of that sleep after we have established alpha block, as Rajni has told you, that suggests that the sleep has started. So once that has started, we let 5 minutes more to go, and then we calculate for that 15 minutes spike wave index. How we do that, we will discuss it out in the workshop. Now, I already told you that these are certain clinical forms, CSWS, Landau-Kleffner. But one important thing is that what Dr. Saurav already said or showed you is B-cells. Now, B-cells also had significant sleep potentiation. The EG appeared quite sinister there also. So you will keep the possibility of ASCS only when there is significant neurocognitive decline is happening. If it is not there, then possibly you are just seeing a B-set. So B-sets, ESCS, or LKS for that matter, this is a spectrum. So BCS is on the benign part side of the spectrum and ESCS is on the sinister side. So we have to choose wisely, because with the moment you say ESCS, the treatment is what? The treatment is immunotherapy. If it is B-sets, the treatment is drugs or sometimes no drugs. So the management differs quite significantly. So this is there are studies, there are collected pool data, which is suggests that the anti-seizure drugs have an efficacy of around 49%, maximum with benzodiazepine, but the best evidence comes from steroids. Best for those with resective or structural lesions, then you have surgery, but otherwise pharmacotherapy is considered, then steroids has the best bet. So we have attempts, what we do is that first we optimize the anti-seizure drugs, make sure that the child is at least on one of them, levetiracetam, valproate with a benzodiazepine for an appropriate duration. If he is on oxcarbazepine, phenytoin, or lamotrigine, we taper them off. And if still the EEG picture and the behavior persists, then we start them on steroids. Then there are two ways of giving steroids. You can choose one depending upon the feasibility at your place. We give at 30 mg per kg pulse for 5 days, and then we give 6 + 6 weeks of oral steroids. Or you can choose a monthly pulses of 20 to 30 with 3 or 5 days depending upon the severity. And you just give monthly steroid pulses for 4 to 6 months without an intervening oral drug. And if there is a response, then it's good. If not, then you need to switch over to other anti-seizure medications, which can be topiramate, levetiracetam, if not tried previously. Ethosuximide can also be tried here. And if there is a lesional ESCS, then you can go ahead with a resective surgery. So with this, my take-home message for you guys is that epileptic encephalopathy are self-propagating states. So here, the only saving grace for you would be an early diagnosis. If you can pick up these etiology differentials, these entities, and start treatment early, then maybe you will be able to stop this relentless progression. Now, EEG is the most useful investigation that we have. Not all have an EEG signature, like Dravet and those they don't have, but the rest do have. So depending upon the age groups, you need to understand that Otahara has got burst suppression. Then MMPSI has migratory ectozones there. West syndrome hypsarrhythmia. LGS has 1.5 to 2.5 Hz slow waves with PFA. And ESCS has got sleep potentiated epileptic discharge. Thank you.